Hello and welcome to Doc Talk Live. Are your shoulders causing you pain? Well, we have someone here who can answer all your questions about treatment options. This is Dr. Neil Pathare. He's an orthopedic surgeon with NorthBay Healthcare. Welcome, Dr. Pathare.
Thank you very much for having me. I'd like to thank Robin and Kelly for setting this up, and thank you very much for joining us this evening. Again, my name is Neil Pathare. I'm an orthopedic surgeon specializing in sports medicine. I treat primarily knee and shoulder pathology, but I do see all parts of the body, any type of orthopedic issues in adults and children. So today we're going to talk a little bit about shoulder issues, specifically shoulder pain in the adult population. There's three main diagnoses that I commonly see. My practice, I'd say, is about 80-85% shoulders, and then the rest is about knee and general surgery, general orthopedic surgery as well. So diving right into it, I have three models here. Maybe if Robin can point at some of these, and we're going to talk about three of the main diagnoses that I commonly see again in the office. So the first most common diagnosis I see is something called impingement syndrome. So over here we have a right shoulder model. Right here, this is the right shoulder looking from the front. So the shoulder is composed of several bones. This is the scapula. This is called the proximal humerus. This right here is the glenoid. Over here we have the clavicle, and then we have a bone called the acromion. So this together makes up what's called the shoulder girdle. Specimen in terms of the different types of anatomy as well, the tendons. In the front we have something called the subscapularis. Over here we have something called the supraspinatus. In front of that we have something called the biceps tendon, and we have the infraspinatus, and we have the teres minor. So all of these in conjunction with your deltoid muscle allow you to raise your arm, rotate it to the side, externally rotate it, internally rotate it, and reach behind your back. So impingement syndrome, what is that exactly? What is impinged? There's a bursa. Bursa is just a fluid-filled sac that provides some lubrication over the rotator cuff, usually right in this position. It's right in the front part of the shoulder. So what happens is right about where my finger is. It provides some lubrication and a little bit of protection from the bone right up top here called the acromion. So when you're raising your arm up, it helps keep it depressed, also provides some lubrication to protect the tendon. A lot of times you can have an injury to the shoulder. You're doing a lot of overhead activities, painting, yard work, things like that. You're reaching up. You can actually pinch that bursa and really inflame it. A common thing I'll hear is females reaching behind their back when they're in their car to get a heavy pocketbook, and that'll set off an inflammatory response. That bursa will get really inflamed, and then they come in to see me and we help them out with that issue. Typically this is going to present with a lot of nighttime pain. Sleeping on the affected side is going to be difficult. Reaching up to do your hair, brush your teeth, putting things away in the cabinet. That's going to be a very common way that these patients will present, common way that you would potentially, the issues that you would be facing. Treatment for this is really simple. We're going to be doing a course of physical therapy, home exercises, anti-inflammatory medications. We'll also do a good course of icing to the shoulder just to help decrease the inflammation in that actual shoulder, in that bursa. The rotator cuff itself can also have a little bit of tendinosis. The rotator cuff tendon can be a little bit inflamed. So all of those things are going to decrease the inflammation. We're going to strengthen up all of the rotator cuff muscles as well as the periscapular muscles. That's the foundation for the shoulder, and that 9 times out of 10 will take care of the issue. For patients that have more severe pain, it's waking them up at night, they can't function, they can't do their job, I always offer them a cortisone injection. So cortisone is an anti-inflammatory medication. Used appropriately, does very, very well. It's just a quick injection right in the back of the shoulder. The first question I always get is how much it's going to hurt. And truthfully, I'd say 9 times out of 10, patients will say that wasn't that bad. And other times they'll say I didn't even feel that. And basically what it is, just a little injection that comes up right here if you follow my finger sideways, and comes up right into this bursal area, this bursal sac. And I move the injection around to make sure that the medication gets all around this area. So that's number one, impingement syndrome. Again, the most common thing I see. Kind of the next spectrum, the next most serious problem that I see is a rotator cuff tear. I'm sure you all have had one or have a family member, a friend that has had rotator cuff surgery. Very common in our population. This is another model, not as in depth as this model, but basically looking like this is what we're looking at. And this is just a fake rotator cuff that we've created here in this tissue. So normally the rotator cuff tissue is attached down to the bone like this. So during surgery, if you're a candidate for surgery, and again, that's something we'll probably have some questions about throughout the course of this talk, what type of treatment do you have for rotator cuff tears? Are you a candidate for conservative management? Are you a candidate for surgery? But just to give you a little depiction, we put these little devices in here called suture anchors. So the suture anchors get put down right at what we call the articular margin. That's right where the cartilage surface is. Once those two anchors, if the tear is big enough to need two anchors, are placed, we basically spread all of these high strength sutures through the actual rotator cuff tendon. You can see here they're spread all the way from the front to the back of the tear to provide a wide spread through the tear. So once all of those go through, we use another suture anchor that goes in the top part of the humerus right here, and we cinch all of these down with the appropriate amount of tension, and we apply that other suture anchor directly in there and hold this in place. So this is basically a scaffold for your body to heal. It's not like a screw putting together a 2x4. It's just a scaffold for your actual rotator cuff to heal back down to the actual bone. So I'm sure there's going to be lots of questions about this. This is the most common procedure I do. I do at least 5 to 7 rotator cuff repairs a month, so obviously quite a bit, especially with this population. The last thing I wanted to talk about was shoulder arthritis. So shoulder arthritis, not as common as knee arthritis, as hip arthritis, because obviously you're not walking around on your shoulders. So it is a lot less common, but nevertheless, being a shoulder surgeon, I do see a fair amount of it in the office. Treatment options usually start with conservative management. It's going to be physical therapy. We can do things like cortisone injections. For patients that actually end up failing conservative management and end up needing a joint replacement, there's a lot of new technology out there that's making the procedure better, faster, more accurate. One of those things is that right here, this is a patient that I'll be operating on in a few weeks. So we actually take a 3D CT scan of the shoulder, and we're able to create these patient-specific guides. So I plan the surgery out ahead of time, and I can tell exactly where I want my implants to go, where I want the screws to be placed. So it makes the surgery a lot more accurate. It makes it more efficient, makes it faster. So you can see here, this is actually a 3D model for a patient of their glenoid. You can see at the side here, they have a large osteophyte right down there. That's going to have to come out. This is not native bone. This is something that the body created. Normally this would be a flat surface all the way around. And basically what I get is this little jig. So after I get an exposure of the glenoid, which is the cut part of the actual shoulder joint, I'm able to take this guide, place it directly onto the front part of the shoulder, and now all the hard work is done for me because I've already sat down at the computer, I've planned out this procedure, and I know exactly where my guide pins are going to go to proceed with the procedure. So really new technology, and it's great. It makes a big difference, and it's kind of becoming the standard of care, so to speak, for these more difficult cases where it can be a little bit difficult to assess your screw trajectory and things like that intraoperatively. So that's why this technology exists.
Wow. Pretty amazing stuff. So let's talk about what they mean by the term frozen shoulder or bursitis. Is this something you see a lot, and what's the difference?
Of course. So again, bursitis is typically a bursa, where you have a fluid-filled sac that's above the actual rotator cuff in this position right here where you see my finger. So it's just an inflammation of that bursa. Along the same spectrum, you can get inflammation, tendinosis of the actual rotator cuff tendons. The frozen shoulder is actually a completely different diagnosis. All joints have a capsule. Right? It's essentially, think of it as a covering, a shrink wrap covering that goes all the way around the joint. So in frozen shoulder, this shrink wrap actually gets really, really tight, gets really inflamed, and it actually compresses down to the point where the shoulder will actually get stuck, meaning patient's range of motion will be absolutely stuck. So if they come in, they'll be trying to lift their arm up, and there's actually a stop to their range of motion. If you try and abduct their arm, they just physically can't go anymore. And it's limited by pain, but it's also a mechanical limitation to the point that they can't go any farther. So I do see this very commonly. Females are at an increased risk. The other things that are associated with frozen shoulder are diabetes and also hypothyroidism. So unfortunately, we don't know exactly what the association is. We do know that there is an association, but the good news is we have a lot of great ways to treat frozen shoulder. Frozen shoulder, very similar to impingement syndrome. I'm going to be offering a cortisone injection the first time I see the patient. That's one of the modalities that's been shown to be a big difference in terms of regaining the range of motion as quickly as possible. So patients will get a cortisone injection the first time they see me in the office. We'll set them up with physical therapy, home exercises. I'll teach them a set of exercises while they're in their office. and teach them the appropriate way to kind of mobilize and make sure that they're stretching the appropriate parts of the shoulder. So in my experience, in my hands, I've luckily, knock on wood, never had to take anybody to the operating room to treat frozen shoulder. There are some cases with really very, very severe frozen shoulder. They don't respond to a cortisone injection. They don't respond to the physical therapy, and you'd actually have to go and do an arthroscopic procedure where you actually do something called a lysis of adhesions, where you actually go in and you cut very carefully in a careful, controlled manner all of the adhesions that exist, and then you perform something called a manipulation under anesthesia, where you actually take the arm physically and you bend it and you tear all of those in a controlled fashion, obviously, tear all of those adhesions. But again, I've never had to do that with my treatment regimen. The cortisone injection, physical therapy, that usually does the trick. At the most, I'll have to repeat a cortisone injection maybe 8 weeks after the first one, and in my hands, that's been very successful.
Okay. We did have a few questions submitted to us in advance. I'm going to ask you a few of those.
Sure.
When you hear your shoulder clicking or popping with no pain, is that normal?
It is. It is. Pain, popping, pain without clicking without pain is not anything to worry about. The times where I get worried are obviously if you have any clicking that's associated with pain. That can be any number of things. That can be a bursitis if you have really thick bursa, a lot of impingement syndrome, a lot of adhesions within the subacromial space. Other things that could possibly be are injury to the cartilage, if you have any loose bodies within the shoulder. So if you just have clicking and things like that, it's a lot associated with age, wear and tear. A lot of structures can get a little bit inflamed. But if there's no pain, there's really nothing to worry about.
Okay. So what if you have an x-ray done and it comes back normal for your shoulder, but you still have pain? Could an MRI pinpoint it more closely?
It definitely could. The full treatment algorithm or workup algorithm, we would have a patient come in, evaluate them with a history, find out what exactly we're concerned about. It would be a history, it would be a physical examination. If the regular x-rays don't show anything and I'm concerned about a certain pathology that I need to work up, then we could definitely discuss an MRI. That definitely is the next step in the treatment management, in the evaluation management.
I think that sort of answers the other question they submitted, which was typically when you see an orthopedic surgeon, what is the typical stuff that you do with a new patient? Is it x-ray?
Yeah.
Is it, have them move their arm?
Right.
What can they expect when they come in?
Exactly, yeah. So again, it's going to be a detailed history, so we'll go over how long you've had the pain. Is this a traumatic injury? Is this something that you've had for years? We'll talk about what side is your dominant side. That's a really important thing for a shoulder surgeon, so we have an idea of what your goals and what your expectations are. I want to know if you're a manual laborer or if you're desk work, right? All of these things are going to key me into what your goals are and then what potential pathology you could potentially have. X-rays are pretty much done at a baseline for the most part. And again, if there's anything I'm concerned about, an acute rotator cuff, for example, like we talked about, patients in their 50s and 60s that have a big fall, and all of a sudden the next day they can't really raise their shoulder up, I have a high degree of suspicion for a rotator cuff tear. So those patients will automatically get an MRI. And then it's on a case-to-case basis. We'll sit down together, come up with a differential diagnosis, and see if an actual MRI is needed.
All right, this person says they have a consult with you next month, and they're wondering if a virtual appointment is possible. And then also, what could cause what feels like loosening? Looseness,
Yeah.
with a sharp pain.
Sure.
If I bend over and reach forward.
Yeah.
No pain above my head otherwise. Happens maybe once a day for the last few weeks.
Yeah. Well, in terms of coming in to see me as a patient, COVID is obviously on the top of everyone's head right now. We are doing everything to be as safe as possible. So all of our patients, before they come in, undergo all the screening questions. So obviously any recent travels, fevers, cough, we're monitoring all of that. All the patients are required to wear a mask as soon as they enter the building. So in all the public areas in the waiting room, as well as when they're waiting in the office, they have to wear a mask. And that's for your protection as well as all the healthcare workers' protections. I wear a mask all day long before I even come into the actual office. So obviously I'm happy to take a look over the phone. It is pretty limited in terms of what we can do over the phone or video. Physical examination entails me actually taking a look at the shoulder, performing examination maneuvers, actually touching the shoulder to see what the actual diagnosis is. But obviously, if you don't feel comfortable coming in, we can always evaluate over the video or do a phone visit. In terms of what you're describing, looseness, these subjective feelings, it could be any number of things. It could be as simple as an impingement syndrome. If you're a younger patient, younger patients, we deal with shoulder instability, shoulder dislocations. At a certain point, when you start getting into patients in their 40s and 50s, shoulder instability, truthfully, isn't as much of a concern unless there's been a big traumatic injury where they have a fracture of their glenoid or something like that per se. But it sounds like this would be something that probably would be best to evaluate in the office, just because I'm not exactly sure what exactly it could be. But again, this would be a perfect example of coming in, sitting down, we could go over the x-rays together and do a detailed examination to figure out what is going on for you.
All right, this person asked in advance, I've been having a deep pain in my shoulder for some time. Aleve doesn't get rid of the pain. At what point should I come in and have it looked at?
Sure. So again, in terms of this patient was having some deep-seated shoulder pain, taking Aleve for quite some time, and they're concerned about when they should come in. It all depends on your threshold. A lot of times, some patients, if they have little aches and pains, they're going to be taking a few Aleve and Advil here and there, and if the pain goes away in a few weeks, obviously there's no need to come in. I will say if it's an acute trauma that's causing all of these issues, or if it's anything that over a few weeks that is really causing you pain, I'd be happy to have you come in and see me. A lot of times, it's just not that serious. Sometimes it could be something more serious, a rotator cuff tear, degenerative tear that you don't know about. So it's difficult to say. It really depends on what your pain threshold is and how much this is affecting you on a daily basis. But I would say, if it is bothering you, we're doing everything to keep all of our patients safe. So please come on over and we can definitely evaluate that for you.
Okay. This person asks, my husband has calcium buildup in his shoulder, according to his physical. What can be done for pain relief as the pain is getting worse?
Sure. So the question was calcium buildup in the shoulder. Now, calcium buildup in the shoulder can be any number of things. There is a diagnosis called calcific tendonitis. So calcific tendonitis, if you look through here again, this is the rotator cuff tendon. You can actually get calcium deposits that form within the rotator cuff. This is very, very, very painful, limited range of motion. One of the best ways to treat this is with the cortisone injection, right? Again, these patients will come in, they're miserable, they can't sleep, they can hardly move the shoulder. One of the best things that we can do for this diagnosis is give a cortisone injection, start them on oral anti-inflammatories, and then get them into physical therapy. In rare circumstances when this doesn't work, there are different options. There's something called a needle localization and barbotage, where we can actually do an ultrasound-guided procedure, and we can actually take a needle and we can actually poke into the actual calcium deposit. And that's also followed by a cortisone injection. In very rare circumstances, if that doesn't work, what we can actually do is do an arthroscopic procedure where we can actually excavate out that piece of calcium and completely remove it. And if it leaves a big enough tear in the rotator cuff, we would actually perform a rotator cuff repair.
Okay. How long after a rotator cuff surgery, how long is the recovery process?
Sure. So the recovery process, I tell my patients, you're basically in a sling for about 4 to 6 weeks. And all of these things change, right? Rotator cuff tears can range from a small 1 centimeter tear all the way up to a massive tear that involves all 3 tendons that are retracted. So all of these things are patient specific. They depend on the quality of the tissue, they depend on the size of the tear, they depend on all of these different factors. So the general kind of spiel that I'll give my patients is you're in a sling for approximately 6 weeks. Physical therapy, range of motion exercises, depending on the size of the tear, the quality of the fixation, meaning the quality of the actual tendon, will start around 4 to 6 weeks. Strengthening exercises will usually start at about 10 to 12 weeks. Full recovery for a rotator cuff tear, you're looking at anywhere to 6 to 9 months. I tell most of my patients, in 6 to 9 months, you're going to have about 85% improvement. It's going to take another 9 to 12 months, or up until the 9 to 12 month point, for you to get basically 100% improvement. So you will see continued improvement in your strength, in your range of motion, and your function all the way up to a year.
Is it common for people who've had the surgery to re-tear their rotator cuff?
That's a good question, obviously a concern. Re-tear is a risk of any type of surgery. The bigger the tear, the larger the risk of re-tear. The older the patient that you operate on, there's obviously a risk of re-tear as well. If you're operating on somebody that's in their late 70s versus somebody in their 60s, they're probably going to have poor tissue quality, so they have a higher rate of potentially re-rupture. So the good news is the results of this procedure are excellent. Studies have shown that even if you get an MRI afterwards and you show that there is a re-tear or non-healing of the rotator cuff, those patients actually function really well. So it is a concern. The data, there's no number I can give you because the chance of a re-tear rate really depends on many, many factors. But I can tell you it's definitely low. It's definitely in the single digits. And again, sometimes when it happens, it really doesn't make a difference in the patient's clinical outcome.
Okay. You talked about giving cortisone shots. How long does a cortisone shot last typically?
Sure. So that's also an excellent question. I get that question very commonly about how long a cortisone injection will last. It really depends on the diagnosis. If we're dealing with something like an impingement syndrome, in my hands, typically I've given one cortisone injection, at the most two, and I'm able to get patients better. Same goes for something like frozen shoulder. In terms of the length of time of improvement for something, say like a glenohumeral osteoarthritis, it really depends. I'll tell patients, I have some patients that undergo a cortisone injection, they'll get a week of improvement, right? And they'll say it helped for a week and now the pain's back. I have other patients that are 6 months out of the injection and they're still feeling great. So it's really one of those things where I don't think anybody can give you a definitive answer. But if you're a candidate for it, I would say try it out. If it's one of these minor diagnoses, hopefully it'll do the trick, and it can really range from a week of improvement all the way up to curative.
How many cortisone shots can a person get, say, in a year?
Sure. That's also another question I get commonly is how many cortisone injections can I get? There's a lot of factors that come into deciding that. So number one is the age of the patient. If we're dealing with a patient, for example, with a rotator cuff tear that's in their late 70s, early 80s, that really doesn't want surgery, they just want some pain relief, they want to be able to regain some function, we're going to have a lot lower threshold to give more cortisone injections. If you're dealing with somebody that's 60 that has a degenerative tear that's pretty large in size, that we have a feeling is going to need surgery, for those patients, I actually don't give any cortisone injections. So the reason for that is cortisone, while it's a great medication, it has to be used appropriately. Cortisone has been shown to deteriorate the quality of the tendon. So you can imagine if there's somebody that's going to be undergoing surgery, we don't want to give them too much cortisone because that can actually affect the healing. There's some recent data out there that has shown if you get repeated cortisone injections, that can actually increase your risk of needing a revision procedure, for example, with a rotator cuff repair. And the thought process behind that is probably because you deteriorate the tendon quality, that it's just not strong enough. The sutures could pull out from it. So that's kind of, and again, that's a great question, but it's a really difficult question to answer. It's more of a kind of patient-specific and diagnosis-specific answer for that.
So if cortisone stops working, is that when you go to surgery, or are there other things that can be done?
It really depends on the diagnosis, but we can talk about some of the diagnoses we talked about. Impingement syndrome, for example. In my hands, very rarely do I have to do an isolated, what we call a subacromial decompression. Subacromial decompression is where arthroscopic procedure, again, where I would go into the shoulder, take a look at the rotator cuff, and then typically there's a bone spur. You could shave that bone spur down and then debride out all of the hypertrophic bursal tissue. For a rotator cuff tear, again, I wouldn't do any more than, in an older patient, one cortisone injection if we know we're going to do a surgery. In a younger patient in their 60s, again, I wouldn't do any type of cortisone injection. So it's really diagnosis dependent. It's a difficult question to answer because there's so many different diagnoses that we deal with the shoulder. But if you're failing conservative management and part of that conservative management is a cortisone injection, one of the next steps could potentially be surgery if you're a candidate.
And do you just work on shoulders, or do you do other joints?
Sure. So my training is in sports medicine, so I focus primarily on shoulder and knee. I am a general orthopedist, though, so I see all parts of the body. I'll see the hip. I'll do hand surgery, wrist fractures, trauma as well, tibia fractures, femur fracture, hip fractures. So I do see all parts of the body, but my specialization, again, is in shoulder and the knee joint.
So do you have any advice for people to avoid having a shoulder injury to begin with?
That's an excellent question. A lot of these issues are hereditary, right? So take, for example, glenohumeral osteoarthritis. Unfortunately, we can't choose who our parents are. A lot of that is just the gene pool. A lot of other issues are with manual laborers, right? If you're doing a lot of overhead activities, your chance of damaging your rotator cuff is probably going to be a lot more than if you're have a desk job. Right? If you're an accountant and you're kind of seated all the time, your arms aren't raised up. So in terms of avoiding injury, and that's also very difficult for a young athletic population. Sometimes injuries happen, right, for football and for soccer and all the other sports athletes that I see. But obviously, you always want to have a healthy diet. You want to work on your muscle tone. You want to work on all your rotator cuff strength, all your periscapular musculature. A lot of baseball athletes that I see, there's a lot of injuries that can be avoided. Believe it or not, a lot of elbow injuries stem from issues with the shoulder. So we do a lot of specific shoulder stretching exercises, strengthening exercise to help prevent all of those things. So, it's really kind of diagnosis dependent, but a lot of it is conditioning, going into the gym, being active, leading an active, healthy lifestyle, and that obviously is just going to be healthy in general for you and also helping your risk of getting any injuries.
So how does somebody get an appointment to see you?
Sure, so excellent question. There's multiple portals in which you can make an appointment with me. The number for the office, 707-646-5599. That's the easiest way. I believe there's also online portals where you can make an appointment. The great thing about my practice, for acute injuries, I always make room for same day if I'm around appointments, next day appointments. We also have an orthopedic urgent care, which is a great option if you're having trouble getting referrals and things like that. This is a way that you can actually make a same day appointment and see me through that manner as well. And then if I'm not around, there's other orthopedic attendings that work different days that I'm not here, and they'd be happy to take care of your injury as well.
How safe is it to come in with COVID going on?
Also an excellent question, how safe it is with COVID. We're doing everything we can to keep our patients safe and ourselves safe. So again, all of our patients are screened at the door, their temperature, to make sure that they haven't had any, don't have a current fever. We ask screening questions in terms of any recent illnesses, any recent travels. All patients are told to, bring in a face covering, covers the nose and the mouth. If they don't have a face covering, if they forgot one, we will provide that for you. And obviously we make it mandatory that while you're in the building, we would like you to keep the face covering on. At the same time, all of the employees, all the physicians, myself included, wear a face mask the entire time. And then the other thing is we obviously do a really thorough clean of each room after the patient leaves to make sure that all the surfaces are wiped down. We always pay attention to personal hygiene even before the procedure. So all the physicians, all the healthcare providers, they're going to be washing their hands before they touch you, before they examine you. They're going to be washing their hands before they leave the room. So this is all standard stuff that is just being reinforced. So, we're doing our best. Obviously, that nothing is perfect. There is a risk anytime you go out to the grocery store. But we are doing our best to keep our patients safe and to keep ourselves safe.
Okay. I think we're almost to the end of our time here. But before we sign off, is there anything else you want people to know about shoulder pain and
Sure.
our orthopedic services here at NorthBay?
Yeah. So just to echo the last sentiment, it's been there's been obviously a lot going on in the world recently. So we are here to help you. We are available. Again, I do want my patients to feel safe. Anybody that's coming in, we are doing all the right things. Ever since the get-go that this started, the administration has been absolutely wonderful. We are on top of it. So if you feel like you have any injuries, any pain, anything that needs to be evaluated, please don't wait. We are doing the safe things and we can safely evaluate you.
Great. Thank you so much, and thank you
Sure.
for everybody who tuned in.
Thanks for having me.